Um, can I start or
Yes, of course.
everyone ready? Okay.
Yeah, everyone is ready.
Um, it's great to be back. And today, the topic I'll be lecturing on is pulmonary hypertension. Once again, it's a very big, broad topic. I don't know why I always pick those, but I'll try to present an approach that makes it easy to understand and helps you get oriented when you're in a clinical setting. Okay, there we go. So I structured today's talk in first the definition, it's one sentence, then the causes, the symptoms, the diagnostics, and I'll finish with the treatment of pulmonary hypertension. So the definition, as I said, it's one sentence, and pulmonary hypertension is defined by an, I think somebody has their microphone. Is defined by an elevated mean pulmonary arterial pressure over 20 millimeters Hg at rest. And the normal area is between 6 and 12, I believe. So this is above 20 is pulmonary hypertension. So the most important thing to understand about pulmonary hypertension is the causes. And once again, as in my shock lecture and as in my heart failure lecture, I've just picked a picture, an image that shows the heart and the lungs, and we'll go through this structure to understand where pulmonary hypertension is coming from. Because I always think that by following blood from where it comes from and where it's going and where something happens and where it's blocked or where it's hypertensive, that just is the easiest way to understand
I'm
and
really
approach.
sorry for interruption, Dr. Conrad. Actually, there are some students that they are not familiar with to how to use this social media stuff. You know, this
Yes, I know.
Zoom room. So they are unable to turn off their Macs. If you could please turn off their Macs because they are constantly disturbing other students and you as well.
Yes, I didn't know I had that ability, but I do.
Yes, you do have.
Okay, perfect.
Yeah.
I think I muted them. Okay,
Yes.
so
Thank you.
I hope I'm clear, understood now. So I was saying that the most important thing to know about pulmonary hypertension is why we have pulmonary hypertension. And the easiest way to understand this is by following the blood, as in any cardiovascular or pulmonary diseases. So right here in this picture, the blood, as always, comes from the venous system, from the superior vena cava and the inferior vena cava. And as we know, the inferior vena cava is of much more importance to pulmonary issues than the superior vena cava. So for pulmonary diseases, the inferior vena cava with deep vein thrombosis and stuff like that, blood comes into the right heart, flows out the pulmonary arteries to the lungs, gets oxygenated there in the ideal world, flows through the pulmonary veins and into the left heart, and from there into the systemic vasculature. So pulmonary hypertension by the World Health Organization is divided into 5 groups. And these groups can be very, it's a very big table, and it's very messy, and it's not easy to learn by just memorizing these groups. It's very hard and not very didactic, but I included it so that when you go back after this lecture and review the topic, you have causes and treatment in one picture and can go back to this as a review slide. But to understand pulmonary hypertension, we're going to look, what does it mean to be group 2 or
Nerede?
group
Dur
3?
di kolami kusum sa tanong tayo inja. Basta yung naranasan.
Sorry, somebody. How do I find who's not muted? Okay. So moving on to how do we organize these groups into a way that we can learn and understand pulmonary hypertension? We go back to this picture, and I put arrows into the picture to see where each group interacts. So group 1 is pulmonary artery disease causing pulmonary hypertension. This is mostly idiopathic and would mostly present in younger female patients around 35 years of age. Group 2 is a pulmonary hypertension resulting from issues with the left heart or left ventricle. Can be also have to do with the mitral valve. So the way this works is that if we have an issue with the left ventricle, the blood collects back into the lungs, and there's a backlog in water and blood, creating pulmonary hypertension. Group 3 is if we have an issue with the lungs. For example, an old male patient who is a smoker and has 30 pack years. This person has pulmonary hypertension classified as group 3. And these numbers, they're not that important. It's much more important to just know, okay, it can come from the left ventricle, from the left heart, or it can come from the lungs. The fourth group, according to the WHO, is if we have a problem resulting in pulmonary hypertension that originates in the venous system. This can, for example, be chronic thromboembolisms that reorganize and collect in the microvasculature of the lungs and then cause pulmonary hypertension. So group 4 sends stuff into the right heart, and these things these emboli collect in the lungs, causing a backlog in pulmonary hypertension. And group 5 is very diffuse. I think they call it, here it's called associated diseases or resulting from unclear mechanism. Exactly, that's the official term. And as you can tell, it's anything that doesn't fit into these groups is put into these groups. And that is sorry, here we go. There we go. Okay, so that's how I approach these groups. As I said, the number is far less important than understanding that anything that affects the left ventricle can down the line and over time and over years lead to pulmonary hypertension. Anything that affects the lungs can eventually lead to pulmonary hypertension. We can have issues with the pulmonary arteries leading to pulmonary hypertension. Chronic emboli from the venous system can collect and lead to pulmonary hypertension, and infiltrative diseases of unclear mechanisms, as the WHO says, for example, sarcoidosis can cause pulmonary hypertension. So what is the danger of pulmonary hypertension? So the reason why pulmonary hypertension is very bad is that it is potentially irreversible vessel damage to the pulmonary arterioles and arteries. So if these are our pulmonary arteries and arterioles, if we have chronic hypertension, this can result in what is known as hyaline arteriosclerosis. And this is basically an exudation of a bunch of proteins that lead to medial and intimal thickening and the vessels becoming narrower. And there's nothing that can be done to reverse this process. So once we have pulmonary hypertension for a long time, there's no going back. So the ideal mechanism of treating pulmonary hypertension is prevention. And it is important to recognize it early on rather than later when the vessels are too thin. So hyaline arterial sclerosis from long-standing hypertension can result in reduced vessel caliber. This is what I mean by this. And in many cases, and this is more relevant for the group 1 pulmonary hypertension, so the idiopathic young female patient who has pulmonary hypertension, they show increased endothelin and decreased vasodilators. And this is important because this is the pharmacological therapy can address the increased endothelin. Looking further down the line, and I referenced this in the heart failure lecture too, pulmonary hypertension, which can result from chronic lung disease, can have very bad consequences for the right heart. And if the heart, the core, is affected by a pathology of the lung, it is called cor pulmonale. So this is right heart failure due to a pathology in the lung and has nothing to do with a pathology in the heart in the beginning. So if cor pulmonale leads to right heart failure, it can eventually lead to structural change, which I will get into in a moment. And if we spiral down this loop, the structural change can result in arrhythmia and, for example, atrial flutter, and also death eventually. So that is why because it is an irreversible vessel damage that can result in bad consequences such as arrhythmia, it is a very important disease to be aware of. So the patient with pulmonary hypertension that comes to the clinic or to the office presents with dyspnea, chest pain that is not relieved by nitrate. For example, if you had acute coronary syndrome. And as I mentioned, a big part of pulmonary hypertension is all these other underlying diseases that cause pulmonary hypertension, and they have various clinical features. So I'm not going to list them here because they are very different. Some chronic heart failure or left ventricle failure patient will have different symptoms than somebody with COPD or with sarcoidosis. So any disease that is mentioned as causing pulmonary hypertension, those symptoms can be added to this list. Let me move on with the diagnostics of pulmonary hypertension. So as I mentioned that the idiopathic pulmonary hypertensive patient looks very different from the pulmonary hypertensive patient who has an underlying lung disease. So that is why the first thing, or the first step to understanding what kind of pulmonary hypertension we have is to just look at the patient in front of us. Is it a young female patient or is it an old male smoker? And this can already be a huge clue as to what type of pulmonary hypertension we're dealing with. Pulmonary hypertension will have the classic symptoms of lung disease, which are cyanosis and can result in clubbing of the fingertips if this goes on for many years. If it leads to cor pulmonale, it can present with symptoms of right heart failure, which can be peripheral edema. They can be jugular vein distension or a hepatojugular reflex. on physical exam, and while listening to the heart with our stethoscope, we can, sometimes it's possible to hear a loud second heart sound, which is often split. The second heart sound is physiologically slightly split, I'll say, and the first part of the second heart sound is from the arterial aortic valve, and the second part of the second heart sound is from the pulmonary valve. And if we have pulmonary hypertension, the right heart needs more time to express its volume into the pulmonary vasculature, and that is why the second part of the heart sound, the pulmonary aspect, is delayed, and that is when we can hear this split much more pronounced as in compared to a physiological split. Just trying to see who's not muted. Okay, I'll continue. So besides the basic physical exam, an easy tool to evaluate for the consequences of chronic pulmonary hypertension is using an EKG. An EKG is anything that is seen on, or the signs that I'm about to go into on the EKG are signs of chronic right ventricular hypertrophy. And we would not have right ventricular hypertrophy in any acute right heart, anything that is acutely demanding of the right ventricle, such as a pulmonary embolism. So right ventricular hypertrophy takes time to develop and is something that is seen in pulmonary hypertension. Right ventricular hypertrophy is also can result in right axis deviation of the heart. If the right atrium is enlarged, this can result in what is called a P pulmonale, which is a P wave that is higher than 2.5 millimeters in these leads. And as I mentioned earlier, pulmonary hypertension can lead to a restructuring of the right ventricle, and this distension and hypertrophy can cause a incomplete or complete right bundle branch block. So what does this look like on an EKG? This is just the EKG from AMBOSS. So, and I tried to show some features. So you can't see the top, but that is okay. You'll get the slides later and then you'll see it there. So when approaching an EKG, obviously the first thing is sinus rhythm, and the second step is to determine the axis of the heart. And as I mentioned, a chronic right ventricular increased demand can lead to right ventricular hypertrophy, and this can lead to a right axis deviation. And the way to look at this, it's also sometimes mentioned in the numbers that are spit out by the EKG, but there's a circle called the Cabrera circle. I don't know if you're familiar with it or if it was presented in your ECG lecture, but these leads can be placed on a circle which show the degree of the heart axis. And if usually 2 should be very positive overall. And in this case, you can see that the positive spike of the R wave is much smaller than the S wave, which means it is overall negative. Same goes for the lead 3. And lead 3 is at the bottom of this. So lead 3 and AVF are inferior leads. And if the heart axis were pointed straight down, this would mean that these are positive. And since they are negative, we have a strong right axis deviation. And the degree is hidden here, but I believe it's over negative 90 degrees. So moving on to the next, so I said right axis deviation, and then we look at the QRS complex. And there are two things that we can look at in the QRS complex. First of all, its duration, and its duration is lengthened. Again, you can't see the numbers here, but another approach to looking at the QRS complex is to see if we have a pointy peaks. Is our R wave peaky and is our S wave peaky? And if something's not peaky, that means there is a delay. And as you can see up here, we have a delay. It's not a singular peak, it's kind of like a roof. Just right here, it's not a clean peak. We have two corners. It goes up, corner, and then another peak. And this is a delayed repolarization, a delayed upper turning point is what I'm going to translate that to right now. So this is signaling that there is an issue with the right bundle because we are looking at V1. If we had this in V5 or 6, and in we would have there would be an issue with the left bundle. But since we have unclear peaks in V1 or in V2, for example, right there, these are signals for right bundle branch block. And depending on the time, it is either incomplete or complete. The next sign to see that we have a chronic hyperdemand of the right ventricle is to see right ventricular hypertrophy. There's this Sokolov-Lyon index, and for the right ventricle, it is calculated as R right, the R peak in V1 or V2, whichever is bigger, plus the S peak, so the S down peak in V5 or V6. If that is greater than 1.05, and it's clearly bigger than 1.05, it's almost 2.3 here, then we have right ventricular hypertrophy. So these are all signs of right ventricular demand that is of chronic nature and which are indicative of pulmonary hypertension. If any, I don't see, oh, here's the chat. Yes, so that's extreme deviation. Exactly. Okay. Okay, moving on to the next slide. So we were talking about physical exam, then EKG, and now we're going on to the next omnipresent diagnostic tool, which is a chest X-ray. So a chest X-ray is going to be of much less help than an EKG in pulmonary hypertension, but it can offer clues. And as I said, the most important take-home message from this lecture would be that you have to figure out what is causing pulmonary hypertension to treat pulmonary hypertension. Just like shock, you have to figure out what is causing shock to treat it. So pulmonary hypertension, what is causing it? And this is also a picture from AMBOSS, and it shows, if you're familiar with the normal cardiac silhouette, you can tell that the top part should be much narrower. And this top bump here is caused by the pulmonary arteries, and this is much more pronounced than it should be, which means the pulmonary arteries are taking up more space, which is a sign of pulmonary hypertension. Furthermore, the left atrium should be down here and a bit better distinguishable with a little more indentations on its borders. And this being the way it is shows left atrium enlargement. So by looking at these two features, we have left atrium enlargement, pulmonary hypertension because we have big pulmonary arteries. This means that we probably have pulmonary hypertension due to a mitral valve disease. And this can, for example, be a consequence of rheumatic disease and rheumatic valve disease. It is very common for rheumatic fever to lead to mitral stenosis. Yes, I think rheumatic heart disease can also lead to mitral regurgitation. Very true. Okay. So moving on to another chest X-ray. This is, for example, a chest X-ray which shows bihilar lymphadenopathy, which is a common cause, which is a classic chest X-ray for sarcoidosis. So a typical, if we have somebody with pulmonary hypertension and sarcoidosis, and this X-ray, they probably have pulmonary hypertension due to sarcoidosis. So the mode of action would be to treat sarcoidosis, because that would probably help with the pulmonary hypertension. And so this would be an example of the group 5 unclear WHO pulmonary hypertension. Okay, so as I've mentioned, the most important thing about pulmonary hypertension is following the blood and understanding where's the issue and what is causing pulmonary hypertension. So again, here's this picture and the WHO group numbers. 1, pulmonary arteries are affected, mostly idiopathic in young females. 2, heart failure of the left ventricle, of the left heart. 3, issues with the lung, for example, COPD or obstructive sleep apnea in obese patients. 4, chronic embolisms, chronic emboli that reorganize and collect and cause to pulmonary artery obstruction and pulmonary artery hypertension. And then 5, the unclear group and infiltrative group, for example, sarcoidosis. So how do we treat all these different approaches? They're very different. So when the heart is hypertrophic, is the pressure more or less in left heart? So that depends. There's 2 different kinds of hypertrophy. I think I'll go into that question later if it's still important. But the pulmonary hypertension due to left heart failure is because the left heart is failing to pump out its whole end diastolic volume, which leads to an increased pressure. And this increased pressure is translated back into the lungs and from there to the pulmonary arteries. So if there's increased pressure in the left ventricle, that will translate to pulmonary hypertension, not decreased pressure. But hypertrophy is a different subject. There are different kinds. So let's go through group by group with some approaches to treatment. And yes, that's what we're going to do. So group 1, as I said, pulmonary arterial hypertension. The issue is with the pulmonary arteries directly. The patient to have in mind for this group is a young female around the ages between 30 and 40 who comes into the office with dyspnea on exertion and says, I'm just out of breath sooner than I used to be. She probably has pulmonary hypertension if nothing else can be found. And the treatment for this is to do a vasoreactive testing. This is done during right heart catheterization, and you give the patient inhaled nitrous oxide. And if they react, then there is a good chance that calcium channel blockers, I just see I misspelled this, I'll correct this later, that calcium channel blockers will be effective in treatment. So it is important we do not treat with nitric oxide, but we test. We test with NO to see if they can be treated with calcium channel blockers. So test with NO, treat with calcium channel blockers. And they are reactive if there's a more than 10 millimeters Hg reduction in the mean pulmonary arterial pressure. Then you should treat with calcium channel blockers. And you should assess their effectiveness after 3 to 6 months. If they are non-reactive or treatment is not effective, you should add these medications. If you remember earlier when I was talking about the pathology of pulmonary hypertension, especially in group 1 in these idiopathic young females, they have an increased endothelin, which is a vasoconstrictor. So if we antagonize the vasoconstrictor, this should help out with our pulmonary hypertension and reduce the increased pressure. Other drugs that help with pulmonary hypertension are vasodilators such as phosphodiesterase 5 inhibitors or prostacyclin analogs. We know sildenafil is a popular phosphodiesterase 5 inhibitor, and iloprost is a prostacyclin analog. Very good. Okay, so moving on to group 2. Group 2 was the left heart failure. Group 2 right here, the left heart. We just talked about group 1. Now we're talking about group 2. So there's a problem with the left heart. Usually, or very commonly, these problems is just systemic hypertension, which leads to remodeling of the left ventricle. So which can then lead to left heart failure. So we have to treat that cause. So hypertension or also diabetes are common comorbidities and causes of heart failure. So we treat the causes of left heart failure. We treat left heart failure itself. For example, in an acute exacerbation, number 1 drug to use is diuretics to release the volume out of the body. And if somebody, for example, the patient whose chest X-ray that was earlier, they might have mitral valve disease. And depending on the severity of the mitral valve disease, it should be mitral valve replacement should be discussed. It is very important to treat AFib. So if somebody has mitral stenosis or mitral regurgitation, mitral valve disease leading to left atrial enlargement, they are at high risk for treating atrial fibrillation. And pulmonary hypertension patients are at an increased risk to the consequences of atrial fibrillation. That is why it is recommended to aggressively treat atrial fibrillation in pulmonary hypertensive patients. If I gave the lecture on heart failure, so if you have any questions about heart failure, or the treatment should be on those slides that you received. So the group 3, again, going back to this picture because it's just very important to always follow the blood and know where the issue is. Group 3, we're dealing with the lungs. The patient to think about for group 3 is a COPD patient or an obstructive sleep apnea patient. These are older people that are overweight and are unhealthy. If you come in and you see somebody, oh, they look really unhealthy, they're overweight, they're smoking, this is probably group 3, contrasting to group 1, who is a healthy appearing young female who is having dyspnea. So Long-term oxygen therapy helps prevent pulmonary hypertension in COPD patients. Somebody who has obstructive sleep apnea should be treated with continuous positive airway pressure therapy at night. Somebody who is obese, morbidly obese, should be treated with weight loss, or encouraged to weight loss, to prevent this obstructive sleep apnea from happening. Anybody who has interstitial lung diseases, they should reduce exposure and or treat the autoimmune causes. There are many medications like methotrexate, MTX, that cause interstitial lung disease. There are lots of autoimmune diseases, for example, systemic sclerosis or lupus that cause interstitial lung disease. These can all be treated with autoimmune therapy. And then I just wrote down 3 other ones, like silicosis is an exposure one, asbestosis, berylliosis, I think, aluminosis, all those metals and stuff, they can lead to interstitial lung disease and might require lung transplantation. Obstructive sleep apnea, yes. TB, very important, TB, yes. So then the final 2 groups are pulmonary artery obstruction. This is what I was saying. Group 4, if you remember, was from down here, the venous problems. This is chronic emboli flowing through the right heart into the pulmonary arterioles and arteries of the lungs, reorganizing and causing an obstruction. These are treated if it becomes so severe to cause pulmonary hypertension, these people are treated with pulmonary endarterectomy. If that is not an option, you can treat it with a balloon angioplasty. The idea here is just cleaning out the arteries or dilating them mechanically. And then the last group, as I mentioned, is this unclear group defined by the WHO, and includes diseases such as sarcoidosis, and the treatment of sarcoidosis is steroids, and which can be escalated with immunosuppressants, methotrexate, and the therapy for sarcoidosis can also include TNF-alpha inhibitors and many more, but I think that's a topic for the sarcoidosis lecture. So to summarize the treatment, you have to know where pulmonary hypertension is coming from and treat the underlying cause. And that is the most effective way of treating pulmonary hypertension. And that concludes my lecture. And I have some review questions for you to ask yourself after having reviewed this lecture. And if you're able to answer these, you have a good overview, and I'd be open to questions now. And I hope you understand the general approach to pulmonary